Hello, and welcome to Acceptance and Commitment Therapy. I am O'Keefe Kelly D'Elia. During today's presentation, our objectives are to increase students' knowledge of acceptance and commitment therapy, apply some of the core concepts of the model, and engage in a discussion about the evidence base for ACT and how we might use it in practice. As we progress through the presentation, think about what type of clients or groups you might use ACT with and how that will look. At the end of the presentation, we'll share thoughts and ideas to critique the model together. ACT was developed by Stephen Hayes in 1982, refined over 2 decades, and published in its current form in a book in 1999. ACT is elaborate and multi-layered, built on many of the same components as cognitive behavioral therapy. Hayes' original model of comprehensive distancing combined behavioral concepts of operational learning from the work of B.F. Skinner with elements of Hayes' own relational frame theory, which draws from the relationships between language, cognition, and emotion. ACT is called a third wave therapy, an outgrowth of CBT, which adds concepts of mindfulness, metacognition, and psychological flexibility, and is focused more on the person's relationship to thought and emotion than on the content of either. ACT could be described as a middle-level abstraction theory, as it describes a limited scope of phenomena, human cognitive and emotional behavior. In practice, it's used as a conceptual model to guide therapy processes and explain why interventions work. There are 6 core concepts in acceptance and commitment therapy. Cognitive defusion is the foundational technique and is related to psychological flexibility. Cognitive defusion is the practice of undoing or defusing the attachment between internal negative experiences, negative thought patterns, and behavior. ACT is guided by the principle that internal negative experiences such as anxiety, worry, fear, and emotional pain are facts of life which are only increased by attempts to avoid or control them. ACT teaches the client to adapt by accepting and observing these feelings and thoughts, maintaining contact with the present moment, and choosing committed action guided by personal values instead of avoidance. Psychological flexibility is increased over time through the practice of mindfulness. The opposing phenomenon, psychological inflexibility or rigidity, is associated with lower quality of life and increasing severity of psychological distress. ACT has been studied in different populations and can be targeted for many different purposes, including for symptom reduction in veterans with chronic pain and PTSD, or in a sample of Hispanic college-age subjects, psychological flexibility predicted lower stress and anxiety. Seeing in 2020 found that ACT was helpful for sexual minorities, those identifying as lesbian, gay, or bisexual, in supporting coping with work stress and life stress. ACT has also been studied across the lifespan, including with depressed youth of different races, ethnicities, and socioeconomic backgrounds. A 2019 case study showed ACT was effective for transgender youth, a group that experiences added developmental and psychosocial challenges during adolescence. ACT may be especially developmentally appropriate for elders. Petkus and Wetherell found lower cognitive fusion and higher resilience in this age group, and that ACT can achieve accepting declines that are unchangeable and identifying goals which are still attainable, congruent with personal values. This is in line with developmental milestones for the last stage of life. In all age groups, avoidant coping is associated with increased risks to mental and physical health. ACT aims to replace avoidant coping with mindfulness and actionable skills. ACT skills and tools can be used with diverse clients in many settings. For clients who choose not to take medication and still struggle with anxiety, negative self-talk, and avoidance, ACT can be an effective and empowering way to offer help. Where access or time are concerns, evidence supports delivery of ACT by telehealth or smartphone applications, or in brief formats like one-day workshops. ACT can help clients cope with circumstances out of their control at any phase of life. The study by Singh in 2020 pointed out that although it is important to continue to create policy changes against discrimination, ACT may provide skills for sexual minorities and others to build resilience and increase well-being in an unjust world. ACT has been put into practice and studied across the world over the last 30 years. Its focus on process and on client-generated goals may make it more generalizable across cultures than some other therapy models. In a 2019 study, psychological flexibility, the core change process model in ACT, was correlated with lower anxiety, stress, and somatization across ethnic and racial groups. Recent work by Ramirez with Latinx adults in depression found ACT was helpful, but also that the study suffered from high attrition rates. Ramirez points out that stigma persists in U.S. Latinx groups around mental health treatment, and that developing strong relationships in the community is key to retaining these clients in treatment. Fung and Wong find that in some people of East Asian cultures, ACT may be more readily accepted as it has similarities to both Buddhism and Taoism. Core components of ACT are found among the Eightfold Path of Buddhism and within Taoist concepts of wellness and harmony. There has also been a lot of research on ACT in West Asian cultures in the last 10 years, most of it positive. One 2019 study, however, found spirituality based therapy was superior to ACT in a sample of religious Muslim elders. Now, looking at generalized anxiety disorder in the context of ACT. GAD is defined by excessive anxiety or worry occurring more days than not for at least 6 months about a number of events or activities and causing significant distress or impairment of functioning. There are many differentials for GAD, and anxiety can be a feature of many other disorders. Psychiatric differentials include social anxiety disorder, panic disorder, OCD, PTSD, or situational anxiety. Medical conditions and substance-related causes should be ruled out, such as hyperthyroid, stimulant use, or alcohol withdrawal. The clinical presentation of generalized anxiety includes restlessness, difficulty concentrating, sleep disturbance, muscle tension, or irritability. For diagnosis, at least 3 of these must be present in adults during the 6-month period, or 1 in children. The onset of GAD is generally in adulthood, but it may occur in adolescents or children. Clients may present as tense, distractible, or hypervigilant, and may have difficulty with an extended interview. Cultural factors influence the experience, diagnosis, and treatment of anxiety disorders. Different languages, assessment tools, and sociological concepts of distress make global comparisons of prevalence challenging. A 2017 JIM article surveying 150,000 adults in 26 countries using DSM-5 criteria found a lifetime prevalence of 3.7% worldwide for GAD, with significantly higher rates in high-income countries. They found 8% in all of U.S. adults. In the U.S., prevalence of GAD varies by racial and ethnic group. Hoffman and Hinton in 2014 found that GAD was most common in U.S. adults identifying as white. This is 8.6%, followed by Hispanic Americans at 5.8%, African Americans at 4.9%, and least commonly in Asian Americans, 2.4%. These authors found that culture-bound concepts of distress and contextual variations in the meaning of psychic and somatic symptoms account for some of the cultural variation in experiences of generalized anxiety. Some instruments used for measuring GAD include the Brief Generalized Anxiety Disorder 7, the Hamilton Anxiety Rating Scale, the OASIS or Overall Anxiety Severity and Impairment Scale, and the PSWS, the Penn State Worry Scale. ACT has been proven in study after study to be effective for many people with generalized anxiety and other disorders. The goal of ACT for GAD is not to eliminate anxiety, but to teach the client how to function better with it. ACT aims to increase psychological flexibility, decrease reactivity to anxious thoughts, and replace avoidant behaviors with mindfulness practices. A 2017 review by Tuig and Levin looked at 36 randomized controlled trials and showed that acceptance and commitment therapy was superior to waitlist conditions and to treatment as usual for depression and anxiety disorders. The same review found that benefits were generally equal to cognitive behavioral therapy, suggesting these may be appropriate alternatives for anxiety disorders, depending on the client's presenting problem, stage of life, personality characteristics, and the goals of therapy. ACT is helpful for situations where the external conditions and internal experiences are unlikely to change or they're unchangeable, and where increasing psychological flexibility may help to improve coping. CBT may be more appropriate where there's an identified problem and where changing, rather than accepting, Internal experiences and response behaviors is the goal. The many references at the end of this presentation provide evidence of ACT's effectiveness in different populations and conditions. It is a model worth learning for the psychiatric mental health nurse practitioner. Now, please consider these items for discussion and to help you think about applying ACT in your future practice. These will also be posted on the discussion board. And these are my references. Thank you very much, everyone, for listening.